Hello, everyone, and welcome to the Flint Community Webinar, your community resource. It's a wonderful day, and I'm super excited because it's my birthday, and there's nothing I'd rather do than be here and bring you these wonderful guests that we have who have wonderful expertise. So super excited to talk to you today. We're going to be talking about healthy benefits of living a healthy lifestyle, and Dr. Matthew Reeves is here with us today to talk to us a little bit about that. After that, we're going to be getting into chronic kidney disease and thinking a little bit about that with Nicole Smith-Anderson from Greater Flint Health Coalition. And as always, in the background, we've got our wonderful experts, Dr. Gordon, Nurse T, and Dr. Harris, who are going to help us out with any information they have to share today. So thank you so much for tuning in. And I'm going to bring Dr. Matt forward. Good to see you today. Thank you, Dr. Reeves. How are you?
Good, thank you. Thanks for the invite. Good to see you all.
Good to see you. All right, so you're going to talk to us a little bit about health benefits of living a healthy lifestyle. What does that mean to you? Like, I hear healthy lifestyle and I think a dozen different things.
Yeah.
So
yeah. Well, we'll get into that. Let me do a share screen into the talk. But yes, there's lots of different definitions of healthy lifestyles, although there's some core ones that we always use, and that's, not smoking, not being overweight or obese, having regular physical activity, whether it's moderate or vigorous, and then, having a healthy diet. And obviously some of these things are a lot easier to measure than others, and healthy diet is always a challenge. But those are the main core components, along with low risk factors. So low blood pressure, not having high cholesterol, not having diabetes. So that's the constellation that we're now working with. And my slides will sort of talk about that, how we got to those constellation of actually what is now eight healthy lifestyle factors that we're tracking. So let me do the share screen, and we can get into that.
That sounds great.
I understand I have about half hour, so hopefully I'll finish up. I tend to talk a lot about things I'm passionate about, so but I'm going to try and finish up by somewhere between 20 past and 25 past, and give us some time for some questions.
That sounds great.
Let's begin. Hopefully you see a single slide there.
Yep.
Good. So yeah, health benefits of living a healthy lifestyle by me, Matt Reeves. I'm a professor of epidemiology. I'm primarily a cardiovascular epidemiologist, working in the area of chronic disease. I do a lot of work with stroke. I used to work for CDC, and I've been at Michigan State for almost 25 years now. So I've been here a long time. And as we'll talk about, I've been interested in healthy lifestyles most of that time. So anyway, thanks for the invitation to talk to you. So let's get into this. So this is a plot of cardiovascular disease mortality over the last 100 years, starting in 1990. And the red line is heart disease. The blue line is stroke. And you can see what happened with heart disease is we had a growing epidemic of heart disease mortality that started in the early part of last century and peaked around 1950 and 1955, but then equally declined rapidly and now is lower than it was in 1990, substantially lower. So you can see we've made fantastic progress on addressing the cardiovascular epidemic, which literally was killing people by the day, particularly in the 1950s and 60s. Obviously, it's still the #1 cause of death in the country, but as bad as that is, it's substantially better than it was 50, 60 or more years ago. So this has been this decline in cardiovascular mortality has been one of the single greatest achievements of public health and clinical medicine in the last 50, 60 years. However, things are always changing. Things are never static. And we should look at what our current unique set of social circumstances and exposures are and consider how they will affect us in the future. What do we expect to happen in this epidemic going forward? And so let's look at the sort of current social circumstances and exposures as they relate to CVD, chronic cardiovascular disease, and general longevity and life expectancy in the US. And, you know, importantly, in the last few years, we've had a remarkable decline in the life expectancy in the US population. This was first documented in 2014. And of course, it accelerated after COVID. So look at this data. In 2019, the average life expectancy in the US was just shy of 79 years, but it dropped to just above 76 years. So almost a threefold difference. That may not seem a lot, but on a population level, that's a massive change, a massive worsening of life expectancy in the US. So that's obviously a great concern. We know that more than 70% of deaths are due to chronic diseases, heart disease, cancer, stroke, diabetes, kidney disease being the big ones. And let's think of then also look at our risk factors in the population. So, you know, we have moderate but stable smoking rates of around a 20% prevalence in the adult population across the US. And that's been pretty stable for the last sort of 15 years. We have poor but stable LTPA. What is LTPA? That's leisure time physical activity. About 25% of the population are completely sedentary, don't do any leisure time or occupationally based physical activity. We have poor dietary habits, and as you all know, increasing levels of obesity. More than 30% are obese, more than 25% of the population are overweight. So we have, low levels of healthy weight in the population. And we have an increasingly older population structure. And we also know that we have poor trends in these health metrics amongst children. So we have we have slightly declining cardiovascular events in terms of risks, but a slowing of the pattern of mortality, and actually reversal with COVID and deaths due to opioids have caused a reversal in life expectancy in this country. We have an ever increasing number of medical interventions that are few of which save money. And we have a high cost, low quality medical care delivery system that does not cover 30 million Americans. So, you know, this is today's sort of current unique challenges towards the chronic disease burden in the population. And we have to consider, what does this mean going forward? So, however, let's step back and think, we often think about medical care as providing a medication, a drug to cure all ills. So let's talk about a drug that, if I told you, would you be interested in a drug that could decrease the risk of major chronic diseases by 70 to 90%, increases life expectancy by 6 to 14 years, delays the onset of chronic disease by 5+ years, produces meaningful increases in quality of life, physical function, and decreases in disability, including dementia, decreases medical expenditures by 1/3, is readily accessible and cheap amongst all those who comply, and have very few side effects. I would imagine that all of you would be interested in this. And it's also effective in virtually all age groups and subgroups that we've looked at. And this wonder drug actually exists, and it's following a healthy lifestyle. If you follow a healthy lifestyle and you're in the lowest risk group, you will see all of the benefits noted on the slide there. So the objective today, I want to show some data from an analysis that really got me into this whole area of healthy lifestyles, looking at the prevalence of healthy lifestyle characteristics in the US. Then I want to summarize the data of why this matters and what are the profound benefits of following a healthy lifestyle on chronic disease risk, longevity, healthy aging, healthcare costs, quality of life, physical function, dementia, and also look at genetic risk. And then if we've got time in part 3, we'll look at some of these new metrics and what are we doing with this information, and critically asking the question, why aren't we doing a lot more with this information? So I got into this when I came up with this idea to look at the prevalence of healthy lifestyles in the US adults. This is back almost 20 years ago. I used data from the Behavioral Risk Factor Survey and published this paper in the Annals of Internal Medicine in 2025, looking at healthy lifestyles in the US in the year 2000. And what we did, we used this nationally representative data of almost over 153,000 people who reported to us, this is a CDC survey, whether they smoked, what their healthy weight was, how often they ate fruits and vegetables, and how often they participated in physical activity. And we use that data to generate an index of healthy lifestyles, summing up these 4 healthy factors. So you could have none of these and get a score of 0, or you could do all 4, which would obviously be the healthiest people, and score a 4 out of 4. Okay, so healthy lifestyles are defined as no current cigarette use, being a healthy weight, which is a BMI, that's body mass index, between 18.5 and 25, so not underweight, but also not overweight and obese. Do you consume 5 or more servings of fruits and vegetables a day? And do you participate in regular leisure time physical activity, which was defined as 30 minutes a day of moderate or vigorous physical activity 5 times a week? Okay, so what did we find when we looked in the data? Well, we didn't find anything too unusual when we looked at the individual characteristics. So as we expected, 76% of the population were non-smokers. Only 40% of the population were at healthy weight. Only 23% consumed fruits and vegetables 5 times a day, and only 22% of the population participating in leisure time physical activity 5 times or more a week. However, the sort of surprising thing is when we added all those things together and say, who does all 4 healthy lifestyle characteristics, this number came up 3%. So only 3% of the US population were participating in all 4 lifestyle characteristics. And, you know, we looked at this by gender and race. So this is the distribution by gender. Males are in yellow, females are in blue. There's a slightly better distribution of healthy lifestyle factors. Obviously, 4 here is the healthiest, 0 is the unhealthiest. Slight propensity of women to be more healthy than men, but not hugely different. We looked at this by race. This is white versus black versus Hispanic versus other. Maybe a slight preponderance or slightly greater healthy lifestyles in these other categories, which are mainly Asian, but really nothing major, nothing different by race and ethnicity across these healthy lifestyle scores. I assume you can see my pointer. Can someone say whether they see my pointer?
Yes.
Yeah. Okay. Good. So yeah. So this we also looked at this by states. These are red is worse, dark green is better. This sort of fits an overall pattern of healthy lifestyles where the West tends to do well, the Northeast tends to do well, the South and Southeast tends to do badly, and Midwest is sort of so-so depending on where you want to define the Midwest to be. So, but again, not a huge amount of variation in these prevalence figures. This is the proportion of people in the state who followed all 4 characteristics. So, you know, not much difference, although a little bit of benefit if you lived out west and then were living in the Northeast. This got a lot of press, which was kind of fun. So these are some editorials in the Washington Post and Chicago Tribune. And then if this worked, this happened.
Here's something interesting. According to researchers at Michigan State University, only 3% of Americans have a healthy lifestyle. Only 3% exercise regularly and eat enough fruits and vegetables. Just 3%. Well, good. That means there's very little chance I'll run into any of these annoying people.
So thank you. Oh, let me see how. Oh yeah. So thank you, Jay, for that. So that was good for me. That was my 2 minutes of fame as a researcher, but it all went downhill after that. But yeah, so that was a lot of fun and a lot of exposure to that. And so the question is, you know, why does that matter? You know, what, you know, yes, it's funny, I guess, but really it's also profoundly worrying. And so in this next section, I want to just briefly overview some of the benefits, reported benefits of these healthy lifestyles. I want to look at these different healthy lifestyle characteristics on chronic disease risks, longevity, healthcare costs, quality of life, disability, dementia, genetic risk. And I'm just going to run over these studies. These are major studies, though. These are studies out of the major population-based cohorts, things like the Nurses Health Study, the health professionals study, N. Haynes data. These are where we go to find this data. These are not fly-by-night studies. These are major investments. And so let's talk about one, which is the Nurses' Health Study, which has generated tremendous amount of information about women's health over the last 30 years. They sampled over 50,000 nurses back in the early 80s and followed them now for 30 plus years. In this particular study, though, they had this constellation of 5 modifiable healthy lifestyles defined as not smoking, not being overweight, participating in moderate or physical activity 30 minutes a day, being in the upper end of this compositive of good diet. They collected excellent diet data in the Nurses' Health Study, and only having moderate alcohol consumption. And there was 2 studies that looked at what is the risk of having coronary heart disease or diabetes in the women who followed that modifiable 5 characteristics. And this is what they showed. And the first thing is to show is that the proportion of nurses who actually followed all 5 healthy lifestyles was extraordinarily low, 3% basically in each study. But the effect of this was remarkable. It reduced the risk of coronary heart disease or diabetes by 80 to 90%. And when you looked at the amount of unhealthy lifestyles, you could calculate this thing that we call population attributable risk. That 82% figure means that if all the nurses followed these 5 healthy lifestyles, if everybody was in that group, we would reduce the coronary heart disease event rates by 82%, and we would reduce diabetes by 91%. So you could basically almost eliminate this epidemic of diabetes and coronary heart disease if you followed these 5 healthy lifestyles. So that's really a profound finding. These are other data. This is data from Mr. Fit, these occupational cohorts, the Chicago Heart Association. Again, look at these numbers. There's 370,000 people followed for 16 to 20 years. Their low risk pattern now includes having low risk factors of blood cholesterol and blood pressure and no diabetes. But only a few, less than 10% of these cohorts had this low risk pattern, but this low risk pattern was profoundly beneficial. It lowered the risk of coronary heart disease mortality by between 5 and 12-fold and increased longevity by 6 to 10 years. So that's data there. Here's data from a European study called EPIC that followed 25,000 men and women who were seen at doctors' practices in East England with follow-up for over 11 years. A 4 score, 0 to 4, healthy behavior score of non-smoking, adequate fruit and vegetable consumption, adequate physical activity, and moderate alcohol consumption. And the nice thing about this data is look at this effect. This is what we call a graded effect. These are survival curves over the 12 years of follow-up, depending on the score. The red line is the people who had no healthy behaviors. The light blue line is ones that had all 4. Look at this graded effect. Basically, if you had all 4, you lived a lot longer than the people who had none of these scores, whose survival declined more rapidly. So that graded effect is something we like to see because that really points to a causal effect of these healthy behaviors. This is a study that looked at healthy lifestyles just in the elderly. So you could say, well, I'm too old now to really start healthy lifestyles. It's not going to have any benefit with me. No, this is a study that didn't sample the people until you were 70 years of age and followed them for the next 10 years. And also found that if the 70-year-olds who had the 4 healthy lifestyle factors had a 3-fold lower risk of mortality in the population. This was a study done in Europe. This is another study combining now the Nurses' Health Study and the Health Professionals Follow-up Study, following 120,000 men and women for 34 years. Again, the same composite of healthy lifestyles, now 0 to 5 that we saw earlier with the Nurses' Health Study. Here then are the survival curves. This is in female and this is in male at age 50. This is saying how much life expectancy would you gain at age 50 if you were participating and had the 5 healthy lifestyles compared to no healthy lifestyles. In women, they gained 14 years of longevity. So women at 50 who had all 5 lifestyle factors, this is this light blue line, gained 14 years of life expectancy. Men, a little less, 12 years. But again, profound gains in life expectancy. Okay, so living longer is fine, but we also want to live longer and better. So it's looking at the function is also important. We don't just want to live long, but have a lot of disability at the time. So this study is important because it looks at function. And it is a 25-year follow-up of a the Physician's Health Study, started in 1981 through to 2006. But critically, they measured, again, the same sort of composite of healthy lifestyles. However, their outcome was late life physical function was assessed by what we call the SF-36. It's a quality of life scale that measures physical function. Outcomes out to 25 years. And this function measured with what we call ADL-like questions. So these are activities of daily living questions. Can you walk? Can you go to the groceries? Can you climb stairs? Do you participate in vigorous or moderate activities? You know, your general mobility and ability to self-care. Scale of 0 to 100, high scores being better. People who were overweight had lower physical function at 25 years out. People who smoked had substantially lower physical function. They were alive, but they weren't as healthy as those who didn't smoke. People who exercised had better physical function than those who didn't exercise. So again, here are lifestyle factors not only impacting longevity, but also the quality and the physical function of that life with the gain in longevity. This is the same data just showing that, yeah, we've already seen that on survival. I'll move past that. Now, okay, so I've shown that this matters for the elderly population as well as middle-aged populations. But what happens? What if you've in a bad healthy lifestyle right now? Does it matter? Does changing your lifestyle, could that have an impact? Is it too late to change, in other words? This study shows that it isn't. Again, this is a follow-up study of the health professionals follow-up study, 50,000 men, 40 to 75 at entry. Same sort of health lifestyle index that they were changing 0 to 5. But what this study did was, over that 20 years of follow-up, record whether you got better at healthy lifestyles or you got worse. So did your score go up or did your score go down? For people who had a lower risk, had fewer lifestyle scores, so they got worse over time, their risk of more CHD went up 50%. This relative risk of 1.48 is compared to people who didn't change the lifestyle score. Whereas those who increased, it went down by 25%. So here's good data to say, no, it does matter. It does matter, A, if your lifestyles improve, that's a good thing. But if they don't improve and they get worse, that's a bad thing. And we've got objective data now to show that. Okay, I could go on and on here. You know, I can show you data on what I think is really important, that Medicare expenditures are 2/3 of that in men and a half less than the rest of the population. If you follow these 5 or 4 healthy lifestyle characteristics, you have medical expenditures, the cost of your care to the government is half that of everybody else. That's remarkable. Okay, data on quality of life, medication use is lower, and less, we're all worried about dementia these days, right? So let's have a quick look at dementia. This is data from France. Looking again at healthy lifestyles in adults 65 years of age living in 3 cities in France who had, this is the unique thing about this study, they had annual neuropsychological testing every year between 1999 to 2016, which means they're monitoring changes in cognition and the diagnosis of dementia. Okay, so they followed those up, same kind of index of healthy lifestyles now, it's Life Simple 7s. We'll talk about that at the end. And look, we're all going to decline in our cognition. That's not the point. The point is you want to slow that decline in cognition as much as possible. In this study, these curves show that the people who had all 7 health metrics, this pinky, whatever this color is, had a slower decline in cognition than the people who had none of the lifestyle factors. So that you had no lifestyle factors, your cognition declined, and each increase in the score was associated with a 10% reduction in dementia. So this becomes very important because now it says that better cardiovascular health means better cognitive health. And this is one of the best ways that we could prevent dementia, is again, just focus on healthy lifestyles. Okay, I'm running out of time. This is genetic risk, but I just want to point out that in this study, they looked at healthy lifestyles within different groups of people who had genetic risk scores. You either have a low genetic risk profile or a high genetic risk profile. In other words, you know, some of our cardiovascular disease events are destined by your genetics. True, but this study did a nice job by looking at the effect of healthy lifestyles within each of these categories of genetic risk. And they showed this gradient of benefit, regardless of whether you're high risk genetic, intermediate risk genetic, or low risk genetic. So healthy lifestyles helped regardless of your genetic composition. So, and it worked independently of genome. So in other words, you can mitigate your high risk, your genetic risk score by following healthy lifestyles just as well as you can if you had low genetic risk. Okay, so, you know, maybe we should open it up to, let's just do a quick summary and we'll open it up from discussion. You know, again, I've shown you the huge benefits to healthy lifestyle, increased longevity by 6 to 14 years. Chronic disease levels of CHD and diabetes go to really low, almost endemic levels. Quality of life improves. You become healthier aging. Medical expenditures decline, and you have less dementia. What is there not to like here? Okay, so we know that the cost of these diseases are massive, right? We spend in $4.1 trillion a year, on healthcare, 90% of which is spent on chronic and mental health conditions. And you can look at these individual risk factors or diseases and just show, you know, hundreds of billions of dollars each year, whether it's smoking, obesity, diabetes. It's just, you know, it's just massive. So this is where the expenditures are spent because we fail to follow these chronic disease and healthy lifestyle factors. So I mentioned Life Simple Sevens. Let me just finish off with AHA's, the American Heart Association concept of ideal health, and that's what we call Life Essential 8s. Okay, so these are the 8 factors that we want to measure the population on and track the prevalence of these Life Simple 8s. And those, again, are the non-smoking, or now they've included vaping in this, not being obese or overweight, participating in regular physical activity, having a high diet score, what we call a DASH-like study. This is the thing that was added. Healthy sleep, getting at least 7 to 9 hours of sleep a night. I fail on this one for sure. And then these ideal health factors, not having high cholesterol, low blood pressure, and having a fasting blood glucose so you're not at risk of diabetes. So that's currently how we're conceptualizing healthy lifestyles and these low risk patterns in the population at large. It's called the Life Essential 8s, and the AHA have done a nice job of bringing in social determinants of health into this whole picture. And there's this paper by Lloyd Jones in Circulation 2022, which I'll be happy to send out, sort of goes over that. Okay, I talk too much, and so I consume much time, but opening that up for questions.
Yeah, I don't think you talked too much at all. This was really wonderful information. Can you go back to slide 44?
You mean this one?
Yes. Okay, so this is an interesting slide to me because I love that you put non-HDL cholesterol, and we know like the correlation between HDL cholesterol and exercise. So to people who don't have a lot of context for what we're talking about when we talk about HDL or LDL, you mentioned like not high cholesterol, but I think you were mostly referring to not high bad cholesterol is what I'm hearing.
Yeah. So you know, without getting into the weeds too much, but yes, there's HDL cholesterol, high density lipoprotein, which is found to be beneficial, although there's some controversy there. But the big thing we worry about is LDL, low density cholesterol. That's the target agent for statins. It's really important to reduce that to levels less than 130 milligrams per deciliter, maybe even less than 100 if you've got at risk. So that's the target of interest in cholesterol, yes. So we're calling this now non-HDL. It's a bit convoluted, but basically it's targeting LDL, low density lipoprotein, yeah.
Got
Bad
it.
cholesterol.
So if we're talking to like our audience who's trying to figure out how to operationalize some of this, right? Because you said, I get it. You don't want us to smoke. You want us to have a BMI that's less than 25, get some activity in. One, what do we mean by moderate or vigorous intensity exercise? What does that look like to people who are trying to think about getting it into their day?
Yeah, right. So this whole area has shifted a lot in the last 15 years because we know people have a hard time, setting the clock to go out and run for 30 minutes or exercise vigorously for 20 minutes. So the pattern is changing now in terms of we want people to accumulate as much physical activity as they can, even if that occurs in short bursts. So even taking the stairs when you go to work instead of the elevator, that's 2 minutes of exercise, and that has a beneficial, whether it's commuting, whether it's walking out for lunch, so trying to get people to think about accumulating activity throughout the day. Obviously, ideally, if you can go out and exercise, it's good for your mental health, good for you. But if you can't, this idea of accumulating at least moderate physical activity. And moderate physical activity is basically, fast walking. Fast walking, it's a MET level of what we call METs, level of at least 4. And so, yeah, that's a whole separate discussion. Be great for these group to get into that, but so we're talking about walking at least and trying to accumulate activity, stair climbing, walking, whatever, throughout the day.
I appreciate you breaking down the idea of exercise into the things that we do throughout our day cumulatively, because one, people will often say, right, like I have patients come to my office and say, gosh, EJ, I'm super busy. It's hard for me to think about when in my day I can do it. And we talk about cumulative exercise, right? Taking the stairs like you suggested, parking further away if that's feasible for you, getting in a walk during your lunch break if that's feasible for you. And I like the opportunity for people to think about the things that they can do in pieces to really contribute to their healthy lifestyle.
Yeah.
You have healthy diet score on here, and you refer to the DASH diet, and I have a little bit of context for that. I wonder if you could talk a little bit about what that means for people.
Yeah. So the DASH diet, the DASH diet is very important because it's one of the few dietary interventions that actually have shown to be proven benefit in terms of longevity and blood pressure reduction. So DASH stands for dietary assessment against hypertension. I can't remember exactly what it stands for, but it's basically a diet that's designed to reduce your blood pressure. So it emphasizes avoiding salt and processed meats, and it's a balanced diet. It's not vegetarian or vegan, but it's basically avoiding things like high salt, high processed foods, high sugar foods, and really, working with more like, natural, and also avoiding refined carbohydrates, right? So those are the big ones: sugars, refined carbohydrates, and salt. And basically the diet, you look at the DASH diet and you can find plenty of recipes. There's whole books on how to cook like the DASH diet. It's similar to the Mediterranean diet. So there's two basic diets that we know there's good evidence that promote better longevity, and that's the DASH diet and the Mediterranean diet, which is more fish, nuts, avoiding red meats. But again, these diets aren't anything onerous. And, they're healthy diets, they look good, and it doesn't mean you have to become a vegan to follow them.
Absolutely. Thank you so much for talking a little bit about that. So when we think about a diet that's meant to prevent or control blood pressure, what does that mean? So we talk about hypertension, right? So when I talk to patients who are coming to my office, I talk about exactly that SBP over an SBP meaning systolic blood pressure over DBP meaning diastolic blood pressure. And I wonder if you'd talk a little bit about that.
Yeah, so you know, we've had basically the message is the lower the blood pressure, the better. I mean, as you know, eventually you could get to a point where that's problematic, but for the vast majority of people, it's not. And so, you know, as we've gotten more and more evidence, and a well-known study called the SPRINT trial that came out about 8 years ago showed that the lower we can take systolic blood pressure, the better the patient outcomes. So it used to be we had a threshold. If we get less than 140, that's good. In my dad's day, you know, it was 150, and you know, he had a blood pressure around 150 for most of his life, and he paid the penalty for that. Now we got the threshold down to 140, but now we're talking about trying to get people into the ideal blood pressure range of less than 120.
Yeah.
Ideally, that comes from following a healthy lifestyle, following a DASH diet, getting regular physical activity, not being obese. But it also means for people who have high levels of blood pressure, of doing a better job with medication adherence, and multiple meds, not being afraid to go to a second medication and maybe even a three-level medication if your blood pressure is resilient to that, is resistant to that, and is still at the 140, 150 level.
I appreciate you having this conversation because there is, so when we talk about blood pressure, right? Blood pressure is the thing that pumps, it's the pressure at which blood moves through our body, right? And we're able to measure that. And we've talked a little bit about those measurements. That top number is sort of how well your blood pressure is moving, how the pressure at which blood is moving through your body. And that lower number is sort of a measure of how your vessels are relaxing, right? And so we measure those numbers, and there are ways we can keep those numbers low, like we talked about. Diet, right, is one. Stress levels might be another. But I appreciate you bringing up this idea of medication, because it may take 1 or 2 medications to control your blood pressure. And you might be doing a great job with your diet and exercise, right? There's this component of blood pressure that can be familial, or that can be due to genetics, right? And so really talking with your provider, and I know we've got Dr. Harris on in the background, would love to bring her up to hear her thoughts, but really working with your primary care physicians to understand, is this medication controlling my blood pressure to where I need to be? And do I need to really be concerned about adding a new blood pressure medicine, right? So one of the things we will often talk about in my office is, let's not be afraid, if we need to start another blood pressure medicine to get your blood pressure within control. And if we get it there and you get your exercise and you're doing a great job with your exercise and you're doing a great job with your diet, then we can pull it back if we need to, right? Because the risks, as you described, of having high blood pressure over time are sort of something that are harder to reverse than if we control blood pressure to begin with.
Yeah, I mean, I always say, you know, high blood pressure is like walking around with a ticking time bomb on your back. You know, it's gonna have an effect on one of these health outcomes, and some of them aren't survivable, obviously, if you have an acute coronary event. But yeah, you're exactly right. Having high blood pressure, even if you're following a healthy lifestyle, is still, you know, people still have high blood pressure, and so we shouldn't be afraid to go to medications. But as you said, as we improve our lifestyles, as we lose weight, as we do more exercise, improve our diets, we can bring that blood pressure down, and we can try trials of removing a medication, particularly if there's a medication that, you know, we think there's a side effect of, whether it's sleepiness or impotence or whatever it is. You know, we can try that, but it's again, the target is to get that top number to less than 140, and really ideally less than 130.
And I think one thing that people don't realize too is that our blood pressure sort of has a natural increase sometimes over time with age, right? Just like some things stiffen up with time, we know that with age, our blood pressure increases. And so it's not necessarily something we're doing. There's a normal sort of physiologic response that we should expect that can happen with age. So listening to your great primary care docs, I see Dr. Harris has come on, is a really big part of that. I I want to hear what Dr. Harris has to say, but I also want to throw out the question about the role of sleep in controlling all of this, right? Because we have had Dr. Robin Tucker come talk to us about sleep and the importance of sleep and how sleep works and what sleep cycles do. But I'd wondered if you'd talk a little bit about why we think sleep is such an important component of this healthy lifestyle and decreasing our sort of mortality over time.
Yeah, and again, it comes from the data that show that people who report better quality sleep and longer duration sleep have better longevity and a lower risk. So it comes from survey data, these type of long-term cohort studies, but also comes from these lab-based sleep studies. I can never say the right word for those sleep tests, but basically we can see really strong adverse cardiovascular effects of people who have sleep apnea or poor quality sleep. And so we can track that to objective adverse effects in the body overnight. So we know that poor sleep is causing physiological changes into the cardiovascular system that we expect to cause poor outcomes. And then on a survey basis, yeah, if you report getting consistent good quality sleep, which I don't always report, you see better outcomes, you see lower risk. So it was a controversial thing to add this because it's another thing for us to track, and a lot of big cohort studies don't have this data. So it's going to take us a while to bring this piece of information into the rest of these other 7 factors. But yeah, it was felt to be important enough, and again, modifiable potentially, right? Modifiable, thinking about your sleep, trying to get into a consistent sleep pattern, knowing that getting 8 hours is important and better than getting 6 or whatever it is. So yeah, we're all at risk again for having poor sleep. It's a risk factor that everybody has to have, and everybody is subjected to poor night's sleep. And the question is reducing that as much as possible.
I think it's interesting that you've highlighted the idea of amount of sleep, but also quality of sleep. 1, 2, I wonder, I wonder if the data has been able to tease out the difference between the outcomes of sleep that are related to things like sleep apnea and how sleep apnea has its own sort of effects that it causes, right? Like, so sleep apnea causes higher rates of high blood pressure, the cardiovascular effects that you've described. How do we disentangle the sleep from the hypertension as like the mortality cause?
Yeah, you're right. Sleep apnea as an entity has its own distinct signal in terms of creating cardiovascular risk. And it's one of the things that affect quality, but of course, there are other things that affect sleep quality. I don't have sleep apnea, but I often don't sleep very well. So yeah, it's complicated. I'm not a real expert in that area, to be honest.
Sure.
So I think we could, be interesting to have someone who does more sleep work in that area. But you're right. Sleep apnea is the most concerning of all the constellation of poor sleep. The presence of sleep apnea and needing a CPAP machine to mitigate that, that's the most concerning thing about sleep. But the idea of sleep apnea tends to happen with middle-aged and older people with a lot of the comorbidities. But this metric is really designed to get people, even adolescents and young people, thinking about their sleep patterns early on and trying to develop a healthy lifestyle towards sleep as well as everything else.
I appreciate that you say this idea of getting our adolescents to sleep, because I remember trying to stay up as a kid and I would give anything for that 10-hour block to sleep now, right? So I'd like to bring Dr. Harris forward to think a little bit about what she sees in the office relative to some of these ideal health behaviors and barriers that you're seeing in terms of getting patients to really be able to operationalize some of this.
Yeah, no, I definitely appreciate Dr. Reeves kind of hearing the progression of the research over the last 20 years, because it definitely emphasizes how much we are not necessarily focusing on our lifestyle choices. For me as a family doctor, I guess there's 2 pieces, and I won't kind of dwell on them too far, but I'll say one, many of my patients come in with cardiovascular risk factors or cardiovascular related diseases. and don't know it. And the challenge with being a primary care doctor is that when people don't know that they have a problem, they're not treating it. But also when you tell them that they have this concern or this medical problem, then they want to move into the lifestyle choices because no one wants to take medicine. And depending on how often or frequently or accessible primary care services are for people, sometimes I'm getting them at the initial point. And maybe those lifestyle choices really can mitigate their problem and stop them from needing medicines. But oftentimes I'm getting them when they've had it for a while, and the idea of lifestyle choices, though beneficial, is not going to cure their problem right now. And we do need to start medicines, and sometimes that's multiple medicines, sometimes it's one medicine. But if you come to me very uncontrolled for a really long time, you're probably definitely a multi-medicine person. And so those conversations get difficult because people don't want to take medicine, but they haven't been consuming the right types of food or moving their body enough in order to be on that non-medicine or diet controlled kind of problem. The other thing I'll talk about in the sleep aspect is a lot more people do have sleep apnea than we think. It's hard to tell, especially when you live alone, or you've been snoring for so long that they haven't really noticed a difference in your snoring, or your medical problems haven't really correlated with a sleep apnea kind of risk or that you're aware of. But one of the things that I like to remind people, whether they have sleep apnea or not, is how impactful poor sleep is as far as the inflammation and the chronic stress that it does on everyone's body. So you could have no medical problems, quote unquote, no medical problems, and poor sleep chronically is going to impact yourself in the 10, 15, 20-year realm. We know that people who work night shift, people who work intermittent jobs where they're basically kind of taking naps throughout the day, that their life expectancy significantly is different than someone who has a regular kind of lifestyle as far as the same kind of sleep schedule, the same kind of lifestyle schedule. And so we know the long-term impact of sleep not only increases your risk of these cardiovascular diseases, but in the long run, unfortunately decreases your life expectancy, which means, you'll die earlier than you might have if you would have just gotten, good sleep on a continuous basis and focused on that versus saying, no, I'll catch up. Catching up on sleep is not a thing. We always try it, but that's not how it works. And so we really need to be proactive about getting quality and consistent sleep, and recognizing that, taking coffee or taking these boosters or trying to do all these things to stimulate ourselves throughout the day because we are getting poor sleep is not fixing the problem. It's just covering it up, which is the same aspect of, people having diabetes and not having a really good grasp of their medical care regarding the balance of the nutrition impacting their blood sugar, as well as the right medicine. So it's multifactorial in a balance, but the more people are aware of what's going on and what they're putting in their body and how well they're sleeping, the better. That being said, and it's my last point, it's hard to focus on your health. It's hard to get that great sleep when you have family to take care or work to do or school to do. And so we understand that. And that's the challenge with our society, is that it's very hard to prioritize your health until something hurts. And if we have a better mindset and collectively, not just kind of in our own homes, then people could take care of themselves, could go to the doctor regularly, could get that regular sleep, could get that vegetable intake that they need and the exercise that they want. But time, as much as 24 hours is a lot of time, for a lot of people, it's not enough time. And so we don't want people to feel bad that they aren't able to do things, because I have my own challenges. Like, I'm an adult. I eat well some days and I don't eat well some days. I work out some days and I don't work out some days. But the goal is that I keep trying, and it is difficult for a lot of people. And I wish collectively we had a better society that supported people taking care of themselves better. But I know it is a challenge, and the idea is that people just keep making small victories, like, maybe the next hour you're drinking more water, maybe tonight you go to bed a little bit earlier, you put down that phone so that way you aren't scrolling and you get some more sleep. So there's small victories that we can do, but collectively we do have a lot of space to make improvements.
I appreciate that so much. Part of the reason we're here on the webinar is because you can't work on what you don't know. And so if you don't know that these are important risk factors, then you can't even work on them. And then we have these wonderful community partners that help break down barriers for people. Because you're right, in a lot of societies where these outcomes are better, we have sidewalks where people can walk all the time. The infrastructure is built for people to increase their exercise, get fruits and vegetables in. Dr. Reeves, I want to give you the last few points. If there are take homes that you want people to walk away with, please let us know.
Yeah, I appreciate those comments from Dr. Harris. I mean, often you are treating people with established risk factors, and so nobody wants to take medications, but it's not just the drug companies trying to make a profit out of medications. Medications work, and they're a key armament of addressing these risk factors. And yeah, I think the idea of small victories every day is the way to do it. I have to be constantly reminded to get up from my chair and walk around the halls and get a little bit of that activity every day, and not just sit here for 10 hours a day in front of my computer. So, but you're right. And I think a societal approach, that's why it's so difficult, because there's nothing that we've done in terms of structuring the environment, whether it's access to food or access to physical activity, or the needed to commute or sitting behind a computer all day. Nothing that we've done in constructing our society makes this easier. And so that's why, we need a lot of education and need people to be really deliberate about these attempts to live a healthy lifestyle. It's not going to come naturally because of the way society is structured.
Yeah. Thank you so much, Dr. Reeves. And cheers. I still love my coffee. Sorry.
I love my tea.
Thank you. Nicole, thank you so much for being here. We talked about hypertension. We talked about all these wonderful modifiable risk factors that we can think about. And I want to think about chronic kidney disease and the resources that we have available to help people who are dealing with chronic kidney disease. So thank you for being here with us today.
Yeah, absolutely. It's kind of the perfect segue. So my name is Nicole Smith Anderson. I am actually with the Greater Flint Health Coalition, but we formed a really fun partnership with the National Kidney Foundation of Michigan, and we're really helping to support their presence in the Flint community and just really educate our community about chronic kidney disease. And so just some stats, within the state of Michigan, about 1 in 7 adults in Michigan have chronic kidney disease, and they don't know it. Also, many adults in Michigan have risk factors for chronic kidney disease. So over 2.7 million have pre-diabetes, nearly 1.2 million have type 2 diabetes, 35% have high blood pressure, and then 70% are obese or overweight. And I actually think that rate's a little bit higher in Flint and Genesee County. And so when we look at chronic kidney disease, a couple of risk factors to be aware of, and we've already talked a lot about these risk factors throughout this conversation today. So when we look at them, we like to break them down as modifiable and non-modifiable. So those modifiable ones are diabetes, hypertension, if there's frequent use of non-steroid anti-inflammatory drugs, and then also a history of acute kidney injury. And then we also have some of those non-modifiable risk factors. So family history of kidney disease, being the age 60 or older, and then your ethnicity. So African American, Hispanic, Asian, Pacific Islander, or American Indian. There are a couple ways to obtain a chronic kidney disease diagnosis. So there are 2 tests, and generally one provides insight regarding your overall kidney function, and then the overall one provides insight regarding the extent of any kidney damage. And typically these laboratories offer these 2 tests as part of a kidney profile. To streamline this process, we obviously encourage you to talk to your primary care physician if you have any concerns or if there's a need for these tests to occur. So one of the things that we're working to support with the National Kidney Foundation is increasing public awareness, right? Because a lot of people have this disease and they're unfamiliar with it. So we're going to be helping to support them in rolling out their Are You the 33% campaign. I would also encourage any community-based organization, if you're interested in interfacing or getting some of these materials, we're happy to provide them. And I think Blair just dropped in the chat the link to take a quiz. So if there is anybody that says, you know what, maybe I am at risk for this and I didn't know, you can take a very short quiz online and it will give you some information. And so this campaign overall is really focused on reaching, educating, and empowering people about their kidney health, and then also increasing some awareness. So I definitely would encourage you to take the test. It's like 5 questions, very easy, I promise. And the biggest thing I wanted to talk about, we spent a lot of the front half of this conversation talking about healthy lifestyles and how we can control some of those things. And what's really wonderful about the Kidney Foundation of Michigan is they have a ton of self-management programs. And so they have programs that are called PATHs. So it's personal action towards health. And they have a kidney version, they have a diabetes version, they have a chronic pain version. They also have a managing high blood pressure program, and they have a diabetes prevention program. Now, what's really cool about all of these is they're all free, and you can actually access them through the National Kidney Foundation website, which I'll share at the end of this. But just to give you an idea of what these PATH programs contain, all the things we've been talking about today, right? So physical activity, medications, decision-making, action planning, breathing techniques, understanding emotions, problem solving, using your mind, sleep, communication, healthy eating, and then also working with your providers. So these are tools that you will be provided as part of these programs. And I think it definitely is reflective of all the important items that we've discussed today. When we look specifically at the Kidney Path program, that's going to be an 8-week workshop for people who are in the various stages of chronic kidney disease and or their caregivers, right? Because oftentimes we want to make sure caregivers are fully aware of everything that's going on. So the intent of the Kidney Path program is really focused on living healthier and building self-management skills, making sure you understand the problems caused by chronic disease, common medications, and then also how to navigate the healthcare system, because that can be tricky. Learning more about the transplant process, and then also you get to engage with a panel of healthcare professionals similar to what we're doing today. When we look at the high blood pressure control program, this is also an 8-week workshop for people with hypertension and their caregivers. It's held in person. There's also a Zoom option. So it's 90 minutes a week, and it's led by certified peers. And so the key topics within this group are hypertension, monitoring your blood pressure, nutrition, which is something we've hit on quite a bit today, tobacco use cessation, physical activity, again, medication management. I know our docs share that sometimes it's better to get started on meds, get those positive health behaviors in order, and then be able to back off of them. Stress management, and again, long-term action planning. And then finally, the diabetes prevention program. The key tenets of that are really adopting a healthy, balanced diet, encouraging folks to lose 5 to 7% of their body weight, and then also encouraging physical activity for 150 minutes per week. And so this program is 16 weekly core curriculum sessions, and we also have a monthly follow-up for 6 months. And it's really focused again on the moderate weight loss and increase in physical activity. And it's in a support group format, which has been really successful. This is a very long-standing evidence-based program that has been successful for many, many years. It also helps to inform individuals on how to monitor fat grams and also total calories. And so if there are specific questions about the programs or you're interested in enrolling, I'm going to have you reach out to our friend Teresa at the National Kidney Foundation. Her email is on the screen, and there's also their website on the page. But it's a tremendous program. We're working to bring more in-person opportunities here in the Flint area in particular. Though there are virtual options and Zoom opportunities, we've kind of found that our community does well when we're able to do in-person. And so we are hoping to roll those out over the next couple of months. But great conversation today. I'm so appreciative of the opportunity to really just reinforce everything that we talked about throughout this entire hour.
No, it wasn't. I mean, this is exactly what we like to see, right? The whole goal is that we're talking about important information and bringing trusted, credible information. And then we're thinking about a resource that our Flint community can use. And the idea that you just provided a dozen different resources where people can learn how to control their blood pressure, they can control their diabetes, they can reach out and understand all of those topics, and have a little bit more of a resource to think about some of the things we talked today is really, really excellent. So we super appreciate your expertise and your time. Shout out to Dr. Reeves, shout out to Nicole, shout out to Dr. Harris. We really appreciate you and all of your expertise today. We have a special webinar next week, and we've got a little slide to talk about it. So next week is a special event. We have like the most wondrous, I don't even know the words to describe Yvonne Lewis, but she is a gem. She is sort of a legend, I will say, and she's going to MC the majority of our webinar next week. That is going to bring us back to our roots. We're going to be talking about COVID, which, as you might know, is how we got this webinar started. And so we've got a wonderful panel of like OG experts, I'll call them. We've got Dr. Wolford coming back. We've got Dr. Kilgore and Nurse T and Latressa Gordon. So we're in really, really great company. And Dr. Sadler. So tune in next week so you can understand what's going on with COVID trends right now and think a little bit about some of the differences in some of the respiratory viruses we're seeing. Thank you all again for celebrating my birthday with me, and have a great week.